Hello everyone and welcome. Today we're diving into a fascinating, albeit challenging, digestive system disease of Mirizzi syndrome. This condition, named after the Argentinian surgeon Pablo Mirizzi, is a rare complication of gallstone disease, and it can lead to significant biliary obstruction and inflammation. Join us as we unravel the complexities of this syndrome, from its causes and symptoms to diagnosis and treatment. So, what actually causes Mirizzi syndrome? At its core, it's almost always linked to gallstones. Specifically, a large gallstone becomes impacted in the cystic duct, or the neck of the gallbladder. Over time, this impacted stone can erode through the walls of the bile duct, leading to inflammation, compression, and ultimately, obstruction. While gallstones are the primary culprit, chronic inflammation and scarring in the biliary tree can also contribute to the development of this condition. Let's break down the pathophysiology, or how Mirizzi syndrome actually develops. The impacted gallstone causes persistent inflammation. This inflammation leads to fibrosis and scarring around the bile duct. The pressure from the stone itself and the surrounding inflammation can then compress the common hepatic duct, or even create a fistula, an abnormal connection between the gallbladder and the bile duct. This obstruction disrupts the normal flow of bile from the liver, leading to jaundice, cholangitis, and other complications. In some cases, the erosion can even involve the duodenum, the first part of the small intestine. Mirizzi syndrome is considered a relatively rare condition. It occurs in roughly 0.5% to 2% of patients undergoing cholecystectomy, which is gallbladder removal. While it can occur at any age, it's more commonly diagnosed in older adults, likely due to the increased prevalence of gallstones in this population. There doesn't seem to be a significant gender predisposition, affecting men and women fairly equally. Now, let's talk about the signs and symptoms. The clinical presentation of Mirizzi syndrome can be quite variable, often mimicking other biliary disorders. However, some common symptoms include abdominal pain, usually in the right upper quadrant, jaundice, a yellowing of the skin and eyes, fever, and nausea and vomiting. Patients may also experience dark urine and pale stools, which are classic signs of bile duct obstruction. Keep in mind that the severity of these symptoms can depend on the degree of biliary obstruction and the presence of complications like cholangitis. Diagnosis of Mirizzi syndrome can be challenging as its symptoms often overlap with other biliary conditions. Initial evaluation typically includes a thorough medical history, physical examination, and blood tests to assess liver function. Imaging studies play a crucial role. Ultrasound is often the first-line imaging modality, but it may not always be definitive. More advanced imaging techniques, such as CT scans, MRI with cholangiography (RCP), and endoscopic retrograde cholangiopancreatography (RCP), can provide more detailed visualization of the biliary tree and help confirm the diagnosis. ERCP can also be therapeutic, allowing for stone removal and stent placement. Mirizzi syndrome is classified based on the degree of biliary erosion and the presence of a cholecystobiliary fistula. The most widely used classification system is the Sendes classification. Type I involves external compression of the common hepatic duct by a stone impacted in the cystic duct or gallbladder neck. Type I includes a cholecystobiliary fistula where less than 1/3 of the circumference of the common hepatic duct is involved. Type IIR involves a fistula affecting 1/3 to 2/3 of the circumference. And type IV is characterized by complete destruction of the common hepatic duct wall. The primary treatment for Mirizzi syndrome is surgery. Cholecystectomy, or gallbladder removal, is almost always necessary. However, the surgical approach can vary depending on the type of Mirizzi syndrome and the extent of biliary involvement. In type I cases, laparoscopic cholecystectomy may be feasible. However, type II often require a more complex open surgical approach. This might include partial cholecystectomy, bilienteric anastomosis, creating a new connection between the bile duct and the small intestine, or even liver resection in severe cases. Endoscopic management with the RCP and stent placement can be used preoperatively to decompress the biliary system and improve the patient's condition before surgery. It's important to note that surgery for Mirizzi syndrome can be technically challenging, and it often requires the expertise of an experienced hepatobiliary surgeon. Unfortunately, there's no definitive way to prevent Mirizzi syndrome, as it's primarily a complication of gallstone disease. However, managing gallstones effectively is key. This includes maintaining a healthy lifestyle, eating a balanced diet low in fat and cholesterol, and seeking medical attention for any symptoms of gallstone disease, such as abdominal pain or jaundice. Early diagnosis and treatment of gallstones can potentially reduce the risk of developing Mirizzi syndrome. The prognosis for patients with Mirizzi syndrome depends on several factors, including the type of syndrome, the presence of complications, and the overall health of the patient. With prompt and appropriate treatment, most patients can achieve a good outcome. However, complications such as cholangitis, liver abscess, and biliary strictures can increase the risk of morbidity and mortality. Research is ongoing to improve the diagnostic accuracy and surgical techniques for Mirizzi syndrome. For example, advancements in minimally invasive surgical approaches and the development of new biliary stents may offer less invasive treatment options in the future. Additionally, studies are exploring the role of genetic factors and biomarkers in the development of gallstone disease and related complications like Mirizzi syndrome.